Your post-MI patient just got an order for metoprolol. Why this drug and not another beta blocker? And why is propranolol a bad idea for your COPD patient? Today we're breaking down alpha and beta receptors, the meds that target them, and how you as a nurse can connect receptors to real-world patient care. Let's make this simple and practical. First, let's quickly review the receptors. Think of them as the docking stations for these medications. Beta 1. You have one heart, so beta 1 receptors are primarily in the heart. Stimulating them increases heart rate and contractility. Beta 2. You have two lungs, so beta 2 receptors are mostly in the lungs. Stimulating them relaxes the airways and also dilates blood vessels. Alpha 1. Think of a faucet handle. These receptors are on blood vessels, and when stimulated, they squeeze or constrict them, increasing blood pressure. And finally, alpha 2. These are like the brake pedal for the sympathetic nervous system. When stimulated, they slow down the release of fight or flight signals from the brain. Keep that simple map in mind, because every drug we're about to cover plugs directly into it. Now, let's look at the medications and what happens when we block or stimulate these receptors. Let's start with the beta blockers. Metoprolol is a beta 1 selective blocker. By blocking beta 1 in the heart, it lowers the heart rate, reduces how forcefully the heart contracts, and ultimately lowers blood pressure. It's cardioselective, meaning it primarily targets the heart. Atenolol is another beta 1 selective blocker, very similar to metoprolol. Because it avoids the beta 2 receptors in the lungs, it's a safer choice for patients with asthma or COPD. Now, what about a non-selective beta blocker like propranolol? It blocks both beta 1 and beta 2 receptors. So yes, it will lower heart rate and blood pressure by blocking beta 1. But by blocking beta 2 in the lungs, it can cause bronchospasm, which is dangerous for someone with asthma. Moving on to alpha blockers. Prazosin is a classic alpha 1 blocker. By blocking the alpha 1 receptors on blood vessels, it causes them to relax and dilate, which drops blood pressure. The biggest nursing watch-out here is first-dose orthostatic hypotension. The patient's blood pressure can drop significantly when they first stand up after taking it, so they need to be educated to move slowly. Then you have drugs that do a bit of everything. Carvedilol is both an alpha and a beta blocker. It blocks beta 1 to decrease heart rate and contractility, but it also blocks alpha 1, causing vasodilation. This dual action of slowing the heart down and opening up the pipes makes it fantastic for managing heart failure. Labetalol is another alpha and beta blocker. It lowers heart rate through its beta effect and vasodilates through its alpha effect. You will see it used a lot in hypertensive emergencies and for managing pregnancy-induced hypertension because it is effective and safe. Let's also talk about direct vasodilators. Hydralazine is a great example. It works directly on the smooth muscle of arterioles, causing them to relax. This reduces the resistance the heart has to pump against, known as afterload. It's often paired with nitrates in heart failure, especially for patients who can't tolerate ACE inhibitors or ARBs. Now let's bring this into the real world with some quick cases. Your post-MI patient, giving them metoprolol or atenolol reduces the heart's workload and its oxygen demand, protecting the damaged heart muscle. As the nurse, you're watching for bradycardia, hypotension, and fatigue. Your patient with COPD and hypertension, you need to avoid non-selective beta blockers like propranolol, which could trigger a life-threatening bronchospasm. A beta 1 selective option like metoprolol is the way to go. You'd be watching for any wheezing or shortness of breath just in case. For your heart failure patient, carvedilol is a superstar. It lowers heart rate and dilates vessels, which not only improves their symptoms but has been shown to improve their long-term survival. Your nursing assessments will focus on monitoring for hypotension, bradycardia, and checking their fluid status closely. What about a patient with both hypertension and benign prostatic hyperplasia, or BPH? Prazosin is a great 2-for-1. It lowers blood pressure and also relaxes the smooth muscle in the prostate and bladder neck, improving urinary flow. Your key watch-out is that orthostatic hypotension, so be vigilant about fall risk and patient education. In a hypertensive crisis, especially during pregnancy, labetalol is often the go-to. It effectively lowers blood pressure without compromising blood flow to the uterus, which is critical for the baby's safety. As the nurse, you'll monitor for hypotension and bradycardia in the mother. and for that heart failure patient who can't tolerate an ACE inhibitor. The combination of hydralazine and isosorbide dinitrate is a common alternative. Your nursing considerations include watching for headaches, which are common, reflex tachycardia as the body tries to compensate for the vasodilation, and a rare but serious side effect with long-term use, a lupus-like syndrome. Now, let's talk about a newer game changer in heart failure, Entresto. This is a combination drug containing sacubitril and valsartan. Think of it as a two-pronged attack. Valsartan is an ARB, or angiotensin II receptor blocker. It works by blocking angiotensin II, a powerful chemical that constricts blood vessels and tells the body to hold onto salt and water. By blocking it, valsartan promotes vasodilation and reduces fluid volume, lowering blood pressure. The other part, sacubitril, is a neprilysin inhibitor. Neprilysin is an enzyme that breaks down our body's natural good guy hormones, called natriuretic peptides. These peptides help us get rid of sodium, relax blood vessels, and prevent negative changes in the heart. By blocking the enzyme that destroys them, sacubitril increases the levels of these helpful peptides. When you put sacubitril and valsartan together in Entresto, you get a powerful combination that decreases both preload and afterload, reduces the strain on the heart, and has been proven to improve survival in patients with heart failure with reduced ejection fraction. Clinically, if your heart failure reduced EF patient is still having symptoms despite being on an ACE inhibitor or ARB, they might be switched to Entresto. As a nurse, you need to monitor for hypotension, hyperkalemia, and changes in renal function. A crucial safety point: a patient must stop their ACE inhibitor for at least 36 hours before starting Entresto to reduce the risk of angioedema, a serious swelling of the face and airways. So, here's the big takeaway from all of this. If you know your receptors, you'll understand why certain medications are chosen for specific patients, and just as importantly, why they're avoided in others. Beta-1 blockers are used to protect the heart after a heart attack. The beta-2 effects are why non-selective beta blockers are risky in patients with asthma or COPD. Alpha blockers are effective at dropping blood pressure but can make your patient dizzy. Hydralazine directly relaxes vessels, making it a key player in some heart failure regimens. Labetalol is a go-to in hypertensive emergencies and pregnancy. And Entresto is truly revolutionizing how we manage heart failure. Next time you grab one of these meds from the Pyxis, you'll understand not just the what, but the why. That's nursing at its best. If this breakdown helped you connect the dots, please hit that like button, subscribe, and share this video with another nurse who might find it useful. And drop a comment below. Which cardiac med do you see most often on your floor? Let's keep learning together. Thanks for watching and for supporting my channel.